This talk is an overview of catatonia. In this talk, I'll review the fundamentals of the diagnosis and treatment of catatonia. Let's start by defining catatonia. In simple terms, catatonia is a behavioral syndrome marked by an inability to move normally. Note that it is a syndrome, not an underlying etiology or pathology. In fact, the exact mechanism that causes catatonia is still unknown. However, it is known that several psychiatric illnesses are commonly associated with catatonia. The most common psychiatric illnesses that lead to catatonia are the mood disorders, including bipolar disorder and unipolar major depressive disorder. These are followed by the schizophrenia spectrum disorders, autism, and delirium. Many medical illnesses can also lead to catatonia, including infections, metabolic illnesses, and neurologic illnesses. In general, if catatonia emerges, it is a sign that the patient's underlying illness is very severe. Catatonia is a fairly heterogeneous syndrome with different subtypes, including hypoactive catatonia, hyperactive catatonia, and malignant catatonia. I'll next review each of these subtypes and the symptoms seen in catatonia. This includes 23 different symptoms, which are measured using the gold standard bush-francis-catatonia-rating scale. Since this is an overview, I won't go into detail on any of these symptoms, but will include resources for further study in the references. The hypoactive subtype of catatonia involves immobility, posturing, staring, mutism, negativism, and withdrawal. The hyperactive subtype involves excitement, impulsivity, combativeness, stereotypy, and mannerisms. Additional symptoms that can be seen in any form of catatonia fit into two categories: rigid and repetitive behaviors, and motor rigidity. Any form of catatonia can progress to the severe and life-threatening malignant subtype, which involves fever, autonomic instability, delirium, and severe muscular rigidity. As I mentioned before, catatonia is a heterogeneous syndrome, with varied presentations incorporating almost any combination of these symptoms. This means that, unfortunately, catatonia is often missed or confused with other diagnoses. Scrupulous use of the Bush-Francis scale can help avoid these mistakes. In general, the higher the score on the Bush-Francis scale, which indicates more symptoms and more severe symptoms, the more likely that a patient has catatonia. Now that we've covered the diagnosis and symptoms of catatonia, let's move on to treatment. The first step in treatment is stopping dopamine antagonists, including antipsychotics. This is because dopamine antagonists increase the risk of progression to malignant catatonia. The next step is performing a lorazepam challenge. This involves recording the patient's severity of catatonia symptoms before and after treatment with a single dose of lorazepam, and noting if there is a change. In most cases, a significant reduction in symptoms after treatment with lorazepam confirms the diagnosis of catatonia. If the lorazepam challenge was effective, then continue to treat with lorazepam and gradually titrate the dose until the patient's symptoms are in remission. This may take days to weeks. Lorazepam monotherapy is effective in most cases of catatonia, but in some cases, particularly more severe cases, additional treatments may be required. The most common second-line treatment is ECT. ECT may also be used earlier if a more rapid response is required, such as in cases of life-threatening malignant catatonia. Additional treatment options are limited and generally supported by only low-quality evidence. These include glutamate antagonists, antiepileptics, and second-generation antipsychotics. That's the end of this talk. I hope this is a useful big-picture overview of catatonia. Thank you.